Hello friends, after a long gap we are again meeting with Dr. Yogita Rokhade ma'am. So you all know about her. She is my anesthetist and highly confident one with the leading practitioner in Bandara. Okay, so today we are having a session on the spinal anesthesia. Yesterday we together have one case which is a high obstetric case with severe PH and her weight was 104 kg. So she was a pre-eclamptic one, but she managed very well. So today we will have a short session to acknowledge such things regarding the spinal anesthesia with her. So, hi Dr. Yogita, my first question is that why we prefer spinal anesthesia in L3, L4 or L4, L5 region, while the spinal cord pain in the L1 region?
It is not basically L3, L4 only. We can give below L1 anywhere.
Okay.
But lower, as you go lower in spinal cord, the spaces are well spaced actually. So it is easier to give prick needle and give drug. As compared to thoracic one, thoracic vertebrae are placed acutely angled and narrower spaces are there.
Yeah.
And if we compare it with lumbar, so lumbar are more transversely arranged. That's why we can hit dura properly.
Yeah.
That's why, and the main thing is spinal cord ends at L1, L2. Mostly upper border of L1 in most patients, and in some patients at L2. Then only nerves are there, not nerve roots. So the chances of injury and the chances of patient morbidity are less.
Okay.
Dura is there, so drug will spread upward only.
Achha.
With CSF.
Achha.
So less chances of injury, easier technique, means less precision required.
Okay.
And nerve injury chances are less. That's why we give at below L1.
Okay.
And in pediatric patient, spinal cord ends at L2. So you should not go above L2. In adult, we can go up to L1 also.
So I think it is difficult while we're dealing with the pediatric patients. Okay. So whether it is blocked first, the sympathetic before the motor block?
It depends on drug. Actually, drug is lipid.
Yeah.
Lipophilic.
Yeah.
Nerve fibers and nerve root are there. So some are myelinated, some are non-myelinated. Some are thin, some are thicker.
Yeah.
We all know this. So this drug is lipophilic. So it will cross lipid layer easily.
Achha.
In ionic form. So basically it is all ion ka combi. So iron का लोचा जैसे होता है वैसे वैसे ब्लॉक सोडियम अंदर जाएगा, पोटेशियम बाहर आएगा, तो उतना सेंसिटाइज हो जाएगा. So myelinated nerves affect late because there is shift of myelination. So drug will not directly act on that nerve. So unmyelinated nerves will affect first. And myelinated nerve will affect later. Same, it depends on thickness. And thinner one will be affect easily
rather than the thicker one.
So that's why then they will carry, some nerves will carry autonomic, sensory and motor. So motor nerve will block first, then sensory and then autonomic. Autonomic will be last one to affect with spinal anesthesia.
Whether this height of the anesthesia means that impact the blood pressure and how we should manage?
Yeah, we all know brain, spinal cord. Spinal cord will have all the vital, with all nerves to vital organs. Around C2 to C4. C4 fibers are usually carry cardiac fibers. They will regulate cardiac functions like cardiac pumping.
Mhm.
Cardiac pumping will regulate blood
Blood
pressure.
pressure.
So when we give anesthesia, so depending on dose of the bupivacaine, lidocaine, whatever we are using, it will if it will cross above if it will cross T4 level, above T2 we call it high spinal.
High spinal.
If it will block T4 level, so T4 will be cardiac fibers.
Yeah.
Then it will hamper
The blood
vitals.
Yeah, and the vitals. Then how you manage in such a case? Means most of the times we have seen that when you give the spinal anesthesia, we prefer little head low position to have that impact. So how it means act on the spinal means give the
We usually give hyperbaric solutions.
Yeah.
Hyperbaric means the drug, that is bupivacaine. Let's suppose bupivacaine is that molecule is combined with dextrose molecule,
Achha.
and it will now with dextrose it will be heavier. That's why we call it bupivacaine heavy.
Acha.
So
Like lignocaine heavy. And that is a bupivacaine heavy.
Huh.
Yes.
So this heavy drug, this will its action will be affected by gravity.
Achha.
Any heavy thing.
Acha.
If we are giving hypobaric or isobaric, basically there are no hypobaric. Isobaric drug, its action will not be affected by any position.
Acha.
Only hyperbaric.
Which drugs they are?
Isobaric.
Yeah.
Isobaric we have levobupivacaine, ropivacaine.
Acha. Okay. So these are means they do not
They are
have
plain
they are
drugs.
plain drugs.
Dextrose is not there to make it heavy.
Heavy. And this means what is the use of this making this heavy elements?
Heavy means the ascent will be not that fast.
Acha.
Drug ascent will be not that fast. So just chances of high spinal and total spinal will be lower with heavy.
Acha. Acha. If in such patients that when we give the spinal anesthesia and they suddenly got the hypotension, how you people manage?
There are 2-3 things. As soon as we give spinal anesthesia, there will be vasodilatation in lower portion.
Yeah.
Affected portion
yeah.
ka, there will be vasodilatation, and above the level, above the block, it will be normal body.
Yeah.
The vessels will be normal.
Normal.
So आपने बहुत बार देखा होगा कि पेशेंट बहुत शिवर करते हैं after
Yes.
spinal
Yes.
anesthesia.
Yes.
So वो भी एक्सप्लेन करता है कि ब्लॉक दिया, ब्लॉक के नीचे वाला वेजोडाइलेटेशन हुआ, पेरिफेरल पूरा कूलिंग हुआ ब्लड का.
Yes. नीचे.
ठीक है, वेजोडाइलेटेशन होने की वजह से कूलिंग हुआ,
Cooling हुआ.
हाइपोटेंशन हुआ.
अच्छा.
ओके,
हाँ.
वेनस रिटर्न कम होके हाइपोटेंशन हुआ. एंड वेजोडाइलेटेशन यहाँ पे है, यहाँ पे नॉर्मल है, तो इट विल बी सेंस ऑफ वेजोकंस्ट्रिक्शन,
Yes.
व्हिच इज द मैकेनिज्म ऑफ शिवरिंग.
Shivering. Yes. Okay.
मैकेनिज्म ऑफ शिवरिंग क्या है कि वेजोकंस्ट्रिक्शन होएगा, बॉडी शेक
Shake
होएगी, तो टेम्परेचर मेंटेन रहेगा.
Yes.
So, हाइपोथैलेमस पे ये एक्ट नहीं करेगा, बट टेम्परेचर रेगुलेशन का इस पे कुछ ये नहीं है स्पाइनल एनेस्थीसिया का, बट वो नॉट मतलब दैट शिवरिंग इज नॉट रिलेटेड टू टेम्परेचर
अच्छा.
कंट्रोल.
Okay, Yogita, how do you manage this hypotension during the cesarean section?
During cesarean or any procedure,
Yeah.
first we will discuss normal procedure, then we will discuss what is special in ANC patient.
Obstetrics.
Even in normal patient, same as we discussed earlier, कि spinal anesthesia will cause peripheral pooling of blood
Yes.
due to vasodilatation
Yes.
and decrease venous return.
Yeah.
So we have to correct it. How we will correct it? By then there comes the concept of preloading and co-loading.
Yeah.
Previously it was preloading. Preloading means ऐसा बोलते थे कि पहले पेशेंट को एनेस्थीसिया देने से एटलीस्ट 5 to 6 minutes पहले 1 liter ऑफ NS और RL लेना चाहिए. Around preloading is 10 ml per kg of IV fluid, which is isotonic to blood.
Okay.
Means RL is most isotonic fluid as of now. Then NS or DNS or whatever other fluids. So we prefer RL in preloading. Then the dose is 10 ml per kg. It should that much fluid should go in patient vessels before the induction of spinal blockade. That was preloading. But now recently we follow the concept of co-loading. Means that much fluid should be go with the anesthesia. Means as we are inducing patient, then that fluid is good.
Okay.
Not necessarily half an hour or 10 minutes prior. Co-loading is better than preloading in controlling post of hypertension.
Sudden hypertension.
Post spinal hypertension.
Okay. Then which vasopressor you prefer?
In ANC patient, normally we use mephentermine as a vasopressor. But in ANC patient, mephentermine is indirectly acting. So it will cause tachycardia first, then tachycardia will increase heart pumping, and then it will increase blood pressure.
Yes.
But what will that done na ki that tachycardia in mother can cause fetal acidosis, hypoxia and acidosis in fetus. So we prefer ephedrine over mephentermine because ephedrine is directly acting, or phenylephrine is directly acting. Phenylephrine is directly acting vasopressor. So it will not cause that much tachycardia, and it is safer for fetus also.
Very important point. You all have to note that how this vasopressor is used in obstetrics patients.
Obstetric phenylephrine is preferred. Obstetric and cardiac patient, phenylephrine is preferred over mephentermine.
Okay. And what about in the severe PIH patients? Means how you deal with the severe PIH patient where the BP has to be, means we have to take the patient at anyhow. But if the BP is after spinal also, if you are feeling that it is above 100 diastolic, then what precautions you take for that?
Severe PIH is double-edged sword actually. We
Yes.
have to take it, we cannot postpone it.
We can't postpone it, yes.
So risk is very high in severe PIH patient, because in severe PIH what will happen with body, to supply blood to fetus, body will increase our pressure, mother's pressure. But there is a problem at placental level.
Yes.
तो इधर से कितना भी प्रेशर बढ़ाओ फिटस को नहीं जाएगा, बट मदर को लगता है कि फिटस को ब्लड जाना चाहिए, इसलिए यहाँ पे प्रेशर बढ़ते रहेगा. सो टर्मिनेशन इज दैट्स व्हाई टर्मिनेशन इज द ओनली. ये सब करते हुए प्रोजेस्टेरॉन इज आल्सो देयर. सो ये सारी चीजें विल इंक्रीज कैपिलरी लीक. So that's why we always see कि PIH का patient will be swollen. There will be ascites, there will be pedal edema, there will be everything.
Even it is very dangerous. So means, when I have seen you, means most of the times even that edema till the lumbar region, above the lumbar region, and anesthetic struggling for the spinal
then we have to displace that edematous fluid.
Yes.
Then properly
you need it like this. Okay. Then means in such patients, means what precaution you take to have any cardiac arrest or something like that?
That due to that capillary leak, we cannot give much fluids. Already BP is high. Fluid patient is already fluid over, means sort of fluid overload condition. So in this case, restricted fluid should be given to patient. for treating post-spinal hypotension, we use vasopressor.
Yeah.
And already patient is on any
Laboratory mostly IV laboratory also.
labetalol, nicardipine. This drug already patient is taking. So we have to think about drug interaction also. There should not be any drug interaction. So mostly management is like this only. Restricted fluid management, then adequate block should be there to avoid any stretching pain. Stretching pain will cause tachycardia, again raising BP.
Yes.
So we have to avoid that. Then some patient sudden hypotension is there in severe PIH patient.
Also.
In severe PIH patient, because that hypothalamus pituitary axis and renin angiotensin system.
Yes.
Drug will block that feedback mechanism.
Acha.
So means maximum time termine and all this doesn't work.
Acha.
Because indirectly acting already feedback mechanism is blocked.
Acha.
That's why directly acting vasopressors should be used in severe PIH.
Acha. And most of the times we have seen that after post-surgery, this means that patient get severe headache, spinal headache. So how to avoid this? Because and let me know कि जैसे PIH patient है, उसको अपन fluid overload भी नहीं दे सकते. What is the dextrose management in such patients? And if the patient is diabetic, how to manage such patients?
First we will discuss PDPH.
Okay.
What is mechanism of PDPH? As soon as we give spinal, there is dura puncture.
Yeah.
Basically, you will be amazed to know that brain tissue doesn't have any pain sensation. If you multiple needle prick in brain tissue, so nobody will know. The only pain carrying fibers are there in meninges.
Okay.
So meninges will carry pain. Brain is already numb.
Yeah.
So when we give dura puncture, CSF will flow back.
Yeah.
CSF will flow back, so pressure will be reduced inside the CSF. CSF pressure will be reduced. That will cause meninges stretch.
Acha.
That stretch will be patient will complain as PDPH, post dura puncture headache. So management first line is जो अपन ने निकाला है उसको डाल fluid replacement. Mostly in summer patient PDPH will be there because dehydration. So hydration is the key to avoid PDPH. Then caffeine will cause cerebral vasoconstriction. So that will be reduced, PDPH will be reduced. Meninges stretch, vasodilatation, PDPH.
Okay.
So we have to act on that mechanism. So hydration, caffeine and paracetamol.
Okay.
Head low position also same की head low position brain का perfusion maintain रहेगा. Pressure ज़्यादा.
And in such patients where we have a restricted fluid management like PIH, so in such patients what we should?
Restricted means you have to give basic fluid. So normal insensible losses है, you have to replace it.
Okay.
Patient को dehydrated नहीं रखना है, you have to replace it. But at the same time कि third space fluid जमा ना हो, उसका ध्यान रखना है. That's why we call it restrictive fluid strategy.
Okay. Thanks a lot for this wonderful session, Dr. Yogita. Students, don't miss the another 2 sessions because she will be there for the next 2 sessions. That for spinal anesthesia, indication, contraindication, and the third one will be on the complications of spinal anesthesia. So stay tuned with us. Thank you.
थैंक यू।
and indications and